neuropathic?
Location.
Location. It is on a weight-bearing point of the foot, so it's on the plantar surface of the foot over the first met head. So bony prominences of the feet are the most likely places to develop neuropathic ulcers. What other characteristics tell us it is neuropathic? What's the shape of the wound? Very round, very clearly defined edges. Also characteristic of neuropathic ulcers. What else? What color is the wound bed? Red. There's a whole bunch of granulation tissue. Very characteristic of neuropathic ulcers. What about the immediate wound edges, peri-wound? It's hard to tell in this picture. This is not macerated skin. It's dry and flaky. As you can see how it's flaking up here. Yeah, so this is a big callus surrounding the wound bed. Yeah, and then what do we call this butt crack of the foot? Fissure. This is what a fissure would look like. So the skin is indurating, and then in a long line, we call that a fissure. So, what would we do to treat this wound? We do need to cover it. What are we going to cover it with? So, we want to keep the wound bed moist, but not too moist. What else is going to be important for this wound? Pressure relief. So, we'd likely put some sort of foam padding around the edges of the wound so that they will not be weight bearing on the wound itself.
Good job, Cotton Eye.
Okay, what type of wound is this guy? Venous ulcer. What are some characteristics that tell us that?
Location.
The location. It's in the typical location of just superior to the medial malleolus. What else do we see? Hemosiderin stains and some varicose veins on the bottom here. What about the shape of the wound? Is it clearly defined? No, it's irregular in shape, also characteristic of venous ulcers. Any evidence of edema? You've got a little bit down here and over here. You can tell where they put their sock, which is another indication that there's a little bit of edema. So this wound, does it tend to be wet or dry? Wet. So what type of dressing do we need? Absorbent. What else do we need to teach this patient to do? Elevate their legs. What else? Ankle pumps. What's even better than ankle pumps?
Calf raises or gait training.
Walking. Okay, what type of wound is this? This is a pressure ulcer. A beautiful one. What stage is this pressure ulcer?
4.
3.
It is a 4. Someone tell me why it is a 4.
Muscle.
This right here is muscle, guys.
She put it on here stage 3. It's on here stage 3.
What's this stuff
I just
right
changed
here?
it, but it was stage 3.
Yellow fluff. What do we notice about the edges of the wound?
I'm gonna
They're
lie.
definitely macerated. This is the white color of what macerated
Give me
tissue
one.
looks like, which means it's too wet. What else do you notice about the edges? Undermining. See how they're curled under? They're curled under. So we would have to stick a Q-tip in all around that to see how deep it goes. Because there could be some tunneling.
Pour little piece.
Depends on what, how much.
Is Christine you want?
It would take you in
Yeah,
particular.
he's doing the chair, the PTA.
Right here.
Let's go back. I forgot to ask on this one. How would you stage this neuropathic ulcer using the Wagner scale?
2.
Okay, so I heard 2. Someone tell me why.
With the
Do you
shoes.
see any tissue besides the granulation? Is there any exposed subcutaneous tissue? No, there is not.
So what stage is it, 1 or 2?
2.
Oh. It is 2.
Oh.
We'll never eat one of those again.
Did he show you the photos?
No, you just did it with a blanket.
Ew. White
Yeah, as far as we can tell, it's a 1. As far as we can tell, it's a 1.
Without substituting.
Because there's no exposure of subcutaneous tissue. This is all just granulation. So this is a stage 1 diabetic ulcer. This is a stage 4 pressure ulcer. This one?
Mm-hmm.
What do you stage it if you can see muscle? Yes. Well, you're supposed to do it, not
I know, I'm
the nose.
questioning.
If there's muscle exposed, what do you grade it? Okay, what type of ulcer is this? Arterial. How can we tell it's an arterial ulcer? Location. It's the distal toes and the dorsum of the foot. What else? It's black necrotic tissue. When in the presence of eschar, can we tell the depth of the wound?
Nope.
No. In order to assess wound depth, all eschar and slough must be removed, but are we going to do that in
Nope.
this case? No, we are not. What else about this wound tells us it's arterial? Yellow nails. What else? There's some pallor mixed with rubor. The edges of the wound are very well defined. It's very obvious where the wound starts and ends. Do you see any hair on the foot? No, and the skin is shiny. That is also typical of arterial wounds. Okay, this beauty. What type of wound is this? Lymphatic. Notice the extreme swelling. Notice how there's lots of tiny, scattered, spread out wounds. You also see pooling. There's a reddish color. These ones themselves actually look kind of dry, but typically these would be very oozing wounds. It looks like this patient also has cellulitis. Changes it a little. Also recommend better footwear and socks.
Those look like comfy. Those look like comfy slippers.
Yeah, but they also look like you could slip out of them and fall.
Thank you, Victor.
And then your leg flies.
I will acknowledge that. Go back to redirect.
Redirect to the screen.
I will acknowledge that.
Okay, any questions
Redirect.
on, you're gonna have to do this in lab for your next practical. You will be given a picture of a wound and you have to identify what type of wound it is and justify it with characteristics that tell you so. You're going to treat the wound also. inflame and treat the wound.
So we're gonna treat picture?
You're going to treat the picture, yes.
Put a bandage on it.
The picture will be stuck to a body part of your partner.
Oh, yeah.
Are you serious?
Smell it.
Are you serious? They do it up a butt.
Okay, we're going to start with this before I let you go. We're going to go over some specifics of other integumentary disorders because you will be asked about these on the board. Cellulitis. Cellulitis is a bacterial infection of the skin and connective tissues. Those who are at risk are older, the immunosuppressed, any sort of trauma to the skin, presence of any other type of wound, and venous insufficiency. So basically, if there's any little hole in the skin whatsoever, it's an opportunity for bacteria to get inside. So as we age, our skin gets much thinner, therefore can tear much easily. And the patient may not even realize it, that they have a small tear in the skin, that a bacteria gets in there, and then their entire limb swells up, becomes inflamed. So what are you going to see if someone has cellulitis? There'll be localized redness that has the potential to spread quickly. The temperature of the skin will be a lot warmer. There may be a local abscess or ulceration. The limb will be tenderness to the touch, and this is a key one. The patient will have chills, fever, and malaise. So when you have cellulitis, it does infect systemically, and you do have a fever. That's how you're going to be able to differentiate between cellulitis and dermatitis. Dermatitis, it does not affect you systemically. Okay, now this is important to know about the redness spreading. So let's say you're in the clinic, you're treating a patient for something else, and they come in with a weird looking leg or wound. Okay, it's a secondary medical issue. You have to figure out whether or not it's an emergent situation. Okay, so you definitely call the PT over. What you do is you draw a line with a Sharpie of where that redness ends. And if that redness spreads, they need to see a physician right away.
Like in what time frame?
Really any time frame. If it gets bigger, you're going to the physician. Because it affects the body systemically, it does require systemic antibiotics, and there is a risk of sepsis and gangrene if it goes untreated. Okay, so back to this lymphatic wound, the reason I said it also looks like they have cellulitis is because of the extreme redness. Okay, and the scabbing wounds here. This is also the one where I told you I think I told you the MD like put a little slit in the woman's knee and then just squeezed out a whole bunch of pus. She had cellulitis of her whole like knee down.
Now it's time for lunch.
Contact dermatitis. This is a superficial irritation which causes a localized inflammatory response, and it can be secondary to exposure to mechanical, chemical, environmental, or biologic agents. So it's essentially an allergic reaction to something. Okay, common responses are people have this contact dermatitis allergic response to nickel, rubber, and latex. So we have to be careful because we use rubber and latex in the clinic with TheraBand and our gloves. So the signs and symptoms would be very localized itching, burning, redness, and edema. Easy to treat, you just have to remove the source of the irritation, and you may apply a topical steroid or anti-inflammatory medication. Anyone know where we most commonly find nickel?
The jean buttons.
Earrings, jewelry, etc. So you get nickel-free jewelry. Okay, eczema is a specific type of dermatitis. It's more chronic, and more commonly due to an immune system abnormality, but it also can be an allergic reaction to an external irritant. Children, infants, and geriatrics have the highest risk of developing eczema. What you'll see are red or brownish gray patchy areas, which will be lichenified, aka thickened, leathery areas, and there'll be lots of itching. Okay, it's going to be treated with topical steroids, possibly oral antibiotics. Cold therapy is great to help reduce the itching. And why is stress management on here?
It can be stress related.
Yeah, so when you're stressed, you are immunosuppressed, and this could be a reaction to stress. Good old stress. Okay, here's some of the fun stuff. Gangrene. There is dry gangrene and there is wet gangrene. Wet gangrene is more dangerous in that it's more quickly spreading. So it's a little bit more of an emergent situation. Okay, so dry gangrene, it's caused by a loss of vascular supply localized, resulting in local tissue death. So we see that with neuropathic ulcers and arterial ulcers. It's most common in the distal limbs. There will be significant pain at the line of demarcation, and it develops slowly over time because of arterial insufficiency or neuropathy. Now, wet gangrene is secondary to a bacterial infection. And what happens is the swelling gets so bad, it will result in cutting off blood flow. It's most common to happen post-severe burns, post-frostbite, or other traumatic injuries. And it's very rapidly progressing, which is why it's more serious and requires immediate medical attention. Okay, so with dry gangrene, you're going to see dark brown or black non-viable tissue, eschar. The tissue becomes a hardened mass. It becomes mummified. The skin will be cold or numb, and again, there's intense pain. So it requires medical intervention, often surgery, sometimes hyperbaric oxygen therapy, because you expose the tissue to more oxygen to help promote healing. With wet, again, we have that severe swelling. It's going to be very painful. The skin will turn first red. As it progresses, it'll turn brown, and then as the tissue dies, it becomes black. It's also common to see blisters that produce pus, and again, it's a systemic reaction because it's due to a bacterial infection. So it requires immediate medical intervention, often with surgical debridement, intravenous antibiotics, and again, the oxygen therapy. Psoriasis. There are 5 types of psoriasis. It is a chronic autoimmune disease that causes an accelerated rate of cell growth. Okay, so it's like one patchy area will overproduce skin cells. So it can happen for a few different reasons. Some people are genetically the genetic predisposition for it. It can happen in response to skin injury. It can happen in response to insufficient or excessive sunlight. Again, it can be an autoimmune stress response. It happens in response to excessive use of alcohol, HIV because you're immunosuppressed, and smoking because smoking does everything. Signs and symptoms, you have red raised blotches. It usually shows up bilaterally. There's itching, lots of flaking, and there's actually what's called psoriatic arthritis, where you get arthritis in your joints and have the psoriasis. So treatment will be topical, possibly systemic, and actually this is one place where we use phototherapy. So sometimes
Take a picture
UV
of it.
light will help reduce the symptoms. No, you don't take a picture of it. Light therapy. Scleroderma is also an autoimmune disorder causing chronic diffuse fibrosis of skin, joints, blood vessels, and internal organs. So the skin will be taut, firm, and edematous, and they will potentially have joint contractures. So because it's autoimmune, it's going to be treated with corticosteroids and immunosuppressants. Lupus. There is discoid lupus and systemic lupus. The one we hear about most often is SLE, systemic lupus. Discoid would be the skin is only affected. The systemic is where the skin, joints, kidneys, heart, nervous system, and mucous membranes are affected. So again, signs and symptoms will be fever and malaise. This is a big one, a butterfly rash across the big bridge of the nose. They also are prone to chronic fatigue, joint pain, light sensitivity, anemia, hair loss, and they often have Raynaud's disease as well. Okay, so they're going to be put on immunosuppressants since it's autoimmune, and then they will, the skin lesions will be topically treated. Polymyositis is an autoimmune disease of connective tissue that ends up affecting the muscles. Okay, but it's under integumentary because it's a connective tissue disorder. So you'll see edema, inflammation, and muscles will begin to degenerate. They are prone to getting dermatitis, and it's going to affect the proximal muscles greater than the distal muscles, but it will be symmetrical in response, and it has a rapid and severe onset. Again, because there's inflammation and it's autoimmune, the patient will be treated with corticosteroids and immunosuppressants. Okay, so what you need to be able to do with all these secondary skin disorders is board questions will describe what the skin looks like and give you 4 choices of which skin disorder it is. So you have to be able to differentiate, okay, well, how is cellulitis different than dermatitis? Because they all have similarities. But try to remember how they differ from each other. Clear? Any other questions? It's already there. Yeah, it's called the same thing, I just updated it. It's 5B.